It's going to be a review of the top 10 papers in shaping infectious diseases and antimicrobial stewardship practices in 2024. And the discussion is going to be led by David Nix, who's a professor of pharmacy at the University of Arizona, and Vanthida Huang, who is also a professor of pharmacy at Midwestern, excuse me, University College of Pharmacy in Glendale, Arizona. So I'll let you guys take it away.
Okay, thank you so much. So, today's presentations, we are going to talk about the top 10 most influential paper. What I want to talk about is I want to say good morning to everyone, and we are honored to be part of this program today. And today we are going to dive into the top 10 paper of 2024, and we will review the literature, looking at the persistent theme of respiratory tract infection, urinary tract infection, and the remaining biggest challenge and opportunity for stewardship. Despite decades of work in respiratory tract infection and urinary tract infection, it's continued to be the top two most prescribed antibiotics across healthcare, as well as in the ED, a long-term care facility. So the paper will be discussed today going to tackle these two areas of work. We're going to move beyond just simple educations and show how to use diagnostic stewardship, electronic nudges, and novel cognitive tools to finally move the needles to high volume syndrome. So I'm going to pass it on to my colleague, Dr. Nix, to start off first, and I'll come back in a second.
Okay, so we're going to talk about articles that addressed issues that stewardship teams typically do that involve interventions and kind of measuring those outcomes. So they're more quality improvement than actual studies, but they are quite mixed. So we're going to start out with an outpatient issue, acute uncomplicated bronchitis, and talk about just the some of the issues that come up and then how can we address those. So next slide, please. So I'm going to call it acute bronchitis from here out. It's uncomplicated bronchitis, but we know that it's caused by viruses in over 95% of the cases. And the duration of illness is typically 2 to 3 weeks. So this is a fine setup for antibiotic stewardship problems. You get an individual that has this cough, and it's basically lasting a week or more, and they call their physician's office and say, I need to do something to deal with this cough. And at any rate, they get in there and they're thinking, I need an antibiotic, and they ask for one. And so they start taking an antibiotic around 2 weeks, and their symptoms start to resolve. And they think the next time they have this problem, they have a situation where they need an antibiotic and they address it even quicker. So this particular site was interested in inappropriate use of antibiotics for acute bronchitis. And they looked at two ICD-10 codes, 20.8 and J20.9. There was one other one that I probably would have included, but one of the problems with these kind of studies is they don't often validate the patient capture. And you would kind of like a sub-study to go and look and see how effective they were at pulling out patients with uncomplicated bronchitis. Was it sensitive enough to where they captured most of the people and things like that? They excluded children, duplicate encounters, follow-up visits for the same illness. They also considered antibiotic use appropriate when the patient also had COPD, emphysema, pulmonary fibrosis, bronchiectasis, any type of immunodeficiency, or another infection diagnosis that would warrant antibiotic use. Next slide, please. So what they did as an intervention is they did this project over 2 years. The first year was kind of a baseline period. However, they did 2 webinars during this period. So in August, September, they did a webinar on ambulatory stewardship. And then in December, they did one on acute bronchitis. Starting in 2021, they did quarterly reporting of antibiotic prescribing. So they had a system set up to where they could analyze the data retrospectively and report how much inappropriate use there was. And basically, if you didn't meet one of those exceptions, you were inappropriately prescribing antibiotics for acute bronchitis. They also included alerts in the electronic medical record that when they went in to order an antibiotic for this particular diagnosis, they would get an alert saying that usually this does not require antibiotic use. It's caused by viruses. So in the end, they compared antibiotic use in 2021 versus 2020, realizing that the 2020 data was contaminated by the two webinars. So next slide, please. So these are the results. And I find them a little hard to interpret because basically acute bronchitis is going to occur in about a 3-month period in the winter. So I'm thinking November, December, January. They found significant difference in post-intervention in the case where you're looking at inappropriate prescriptions as a percentage of total cases of acute bronchitis. They found significant differences in March and also October, November. All the rest of them were not significantly different. You could see some that had trends. So this is at the period when they would be prescribing most likely for acute bronchitis. But if you go to the next slide, in the pre-intervention period, they had 4,700 encounters for acute bronchitis. Antibiotics were prescribed for about 45% of those. In the post-intervention period, there were 3,500 encounters, and antibiotics were prescribed for 32.5%. So it looks like there was some benefits of probably including those reports, which went to the clinic supervisors and leads. And there was also these alerts that came out on the ordering system. The other thing that was noted in inappropriate prescribing was a little bit more common in clinics compared to urgent care. And this was probably because urgent care does more protocol-driven care. Next slide, please. So that's just one example of a study that you could do out in the outpatient setting. And I know in my own facility, Dr. Galgiani has done that with coccidioides, trying to look at for ordering testing to see if somebody has coccidioides when they have community-acquired pneumonia. And that's really worked well. So the next topic I'm talking about is going to the other extreme. This is a bone marrow transplant unit, and they are looking at individualized antibiotic plans for quality improvement. And this was designed to reduce carbapenem use in kids that are undergoing hematopoietic stem cell transplant in a freestanding pediatric hospital. Next slide. So they looked at 3 conditions. One is the pre-engraftment period, looking at neutropenia prophylaxis, treatment of febrile neutropenia in a hemodynamically stable patient, and empiric treatment of patients with fever and hemodynamic instability. So what they did basically is they went ahead and tried to plan ahead. And at the time the patients were being conditioned for the transplant, they would write plans as to what would happen if they got into one of those 3 conditions as things went along. There were updates done over time if somebody was found to have a new allergy or something. The therapy included ceftazidime as a backbone. And then if the patient had risk factors for MRSA, or if they had instability of blood pressure, they would be given gentamicin and possibly vancomycin. If they were known to have an MDRO, they would be given a carbapenem. And they did surveillance cultures of the nasal swab for MRSA and stool for VRE and ESBL producing Enterobacterales. They also included information on allergies to where they could come up with a plan for what to do in those cases as well. Next slide, please. So this data was analyzed using a interrupted time series analysis. So it's basically 3 periods here. There's the initial period before when these individualized plans were not being used. There's a period of a year in the middle there where the individualized antibiotic plan was used. And then they added on some handshake type stewardship for the last period. And one of the things that I learned a long time ago with regression analysis is you don't try to fit regression lines when there looks like there's nothing there. And that's essentially what's done with this type of analysis. So if you look at the middle period, for example, where it looks like antibiotic use is coming down, that's not real. And we shouldn't read into it. The other thing that I find the most interesting is when you look at that time period, each dot represents a month of data on the days of therapy of antibiotic coverage per 1,000 patient days. And if you look at that, they were periods of a whole month where someone would not get meropenem at all, no carbapenem. So what I would be looking at is those people that had high usage, or those months that had high usage compared to the months that they were very low usage or none at all, and try to see if you can figure out what was different about those. My guess is it's the prescriber, but there might have been other stuff going on as well, but the data was not really provided for that. But I would not venture to say that there were any major changes in any of those. It does look like there were more months where there were not outliers of high prescribing once the stewardship came into play. There's also on the right there, you see the usage of ceftazidime, cefepime. If anything, meropenem went down slightly. Cefepime, ceftazidime might, it's hard to say, but it might have trended up slightly. Next slide, please. This is total antibiotic use. My conclusion would be there looks like a trend at the end once you had both stewardship and these plans in place, where there might have been reduced overall antibiotic use. But again, kind of hard there's a period of 6 months there where you can really say it seemed to be a little bit lower. Next slide. This was the overall patient days. And, this is a little bit outside. I was talking about respiratory tract infections, but I wanted to include this paper. The theme is mostly respiratory tract infections. But these were over 9,000 patient days and approximately 200 in each group that got these stem cell transplants. And you can see there was no difference in outcomes, bloodstream infections, MDRO bloodstream infections. They didn't have higher safety concerns or anything like positive Clostridium difficile test. And they didn't have increased mortality that was unrelated to relapse of their malignancy. Next slide. So this last study, it's not really a last study, but this 5-year study looked at empiric antibiotic order sets on antibiotic use metrics in hospitalized patients. Next slide. So this was a 750-bed academic medical center in upstate New York. They had a traditional stewardship with a quarter FTE physician and 1 full-time pharmacist. There was also some academic support. There was 1 faculty member that helped out and provided support and 1 resident. They had implementation of antibiotic order sets in 5 phases. Before this time, they had no order sets or anything like that. It was just on a regular blank piece of paper. Next slide. So this is an example of the order set for community-acquired pneumonia. If this is an adaptive form, so if you were to check community-acquired pneumonia without risk factors for multi-drug resistant organisms, you would get back ceftazidime and azithromycin as the recommended therapy. If you say that the patient had increased risk factors for multi-drug resistance, you would get back a lot more information and be asked about other therapies. So we've done that at my institution before, and we found that the usage of anti-MRSA and anti-pseudomonal therapies was much higher than it needed to be. The incidence of those type of infections in community-acquired pneumonia is actually pretty low. So you tend to do that only in patients admitted to the ICU. And this was not, I mean, it did include some ICU patients. So there, I don't know what percentage. So if you check community-acquired pneumonia with risk factors, you would be asked if you have MRSA risk factors, whether or not you had Pseudomonas risk factors, or both. And that would trigger adding vancomycin and potentially adding anti-pseudomonal therapy. And then there were their preferred regimen for anti-pseudomonal therapy was piperacillin and tazobactam. I don't necessarily agree with that in all cases. Sometimes it's not a good idea to include anti-anaerobic therapy if you don't need it. But that was their setup. And you can see that there's a checked box for azithromycin, and that would come out on the recommendation. For MRSA, you could use either linezolid or vancomycin. Next slide, please. So this is their antibiotic use in response to implementing those order sets. And you can see 5 periods of implementation where they were sort of changing things and adding more order sets. They're kind of between those dashed lines. And the 3rd and 4th little section there was during COVID. And you can see gaps in between, and basically they did not do this while they were changing over residents in July and August. So there was a 2-month gap between all of those. So overall, the first one looks at antimicrobial days per 1,000 patient days. And you can see that it started coming down. It took a gap at COVID and pretty much flattened out. A lot of centers would see increased use of antibiotics there. And then it started down again. On the right, you will see use of specific agents. Fluoroquinolones is the first in the upper left. There's, let's see, clindamycin is on the bottom there on the left side. And you can see there was a decrease in all the antibiotics. Next slide. And this is Clostridioides difficile infection cases, showing that they also went down, but flattened out kind of at the end when they reached kind of an endemic level, I guess. Next slide. So this next one is an example of diagnostic stewardship. But I always consider diagnostic stewardship tied pretty closely to antibiotic stewardship. And this was looking at patients with ventilator-associated pneumonia. And it was more of a proof of concept. And whether or not, one of the things I always wonder in these cases, are they still doing it after they did this study? And I don't know the answer to that. I should have asked Kim Clays. So next slide, please. So ventilator-associated pneumonia, there is a significant risk of getting pneumonia the longer you have endotracheal tubes in. And part of the reason is that the tube becomes colonized and you get aspiration around the cuff of that endotracheal tube. And it's always really hard to distinguish pneumonia in these cases. A lot of times the patients have a lot of underlying pulmonary disease. They may have some heart failure. They may have other problems that make interpretation of the chest x-ray somewhat difficult. I know there's been studies where they have 3 different physicians looking at the chest x-ray, and they all sometimes come up with different answers. But there's also a continuum of disease. So when you first put in the endotracheal tube, over time, there's a higher risk of colonization and higher risk of pneumonia. But you also have purulent bronchitis, where they have increased pulmonary secretion, increased suctioning, and all of that, and don't necessarily have fever and white count elevations and all that. And sometimes those get confused. And there are physicians that believe you should treat patients earlier when they have purulent bronchitis. And there are others that would wait till the patient has pneumonia. So positive respiratory cultures, when they're obtained, weigh very heavily on the decision to treat. But colonization is common, so we have to worry about distinguishing. So the goal in this case was to evaluate whether some modified culture reports would affect the antibiotic use. Next slide, please. So essentially, they look for increased oxygen requirement or increased PEEP requirement, fever, hemodynamic instability, or change in white blood cell in conjunction with chest x-ray. And if they didn't have an infiltrate on chest x-ray that they could discern, then it was considered an inappropriate culture. So you had to have these things together to say that the culturing was appropriate. So what would happen is you would do a culture. Within 24 hours of that culture, an ID physician and an intensivist would go and look at it and say, this is appropriate or not. They would notify the laboratory of the appropriateness. If they told the laboratory that it was inappropriate, the laboratory would not report the identification and susceptibility. They would say something. I'll show you the exact comment when we get to the next slide. But at any rate, the physician would have to call the laboratory and say, could you give me the full report in order to get further? So next slide, please. So 6 months post-COVID-19 pandemic was when the study was conducted, just to give you an idea of what was going on. The lower respiratory tract cultures were reviewed within 24 hours, and then microbiology was notified. So if it was inappropriate, they would report that organism recovered in this culture may represent colonization or contamination and not true infection. And that's all they got. If the physician requested a full report, they would get the ID and susceptibility test result. But there was no direct intervention. Nobody got called, and no recommendations beyond that statement went out. Next slide, please. So it turned out that 79% of these lower respiratory tract cultures were considered inappropriate. A third completed antibiotic therapy for VAP, even though they had inappropriate cultures. More than half had potential pathogens identified, and 46% of these were given full course of therapy for VAP. Inappropriate cultures are frequently positive for potential pathogens and drive overtreatment of VAP. Next slide, please. So basically, this study showed that the modification of the respiratory culture result reporting to indicate potential colonization might be useful to reduce antibiotic therapy for VAP, and further study is warranted in this case. Next slide, please. So this was the last study I wanted to talk about, and it's a little bigger than the majority of these type interventions. It was done at the largest healthcare conglomerate in the US, and it involved quite a few hospitals, community-based hospitals. It was called the Inspire Randomized Clinical Trial, and Dr. Huang is going to talk at the end about a companion to this that was done in urinary tract infection. So next slide, please. So you can see this is a large population, almost 50,000 men and women in 59 community hospitals. They cluster randomized these hospitals into a computerized provider or entry bundle versus routine stewardship. And the primary outcome was use of extended spectrum antibiotic days of therapy. Next slide, please. So the standard treatment for CAP in this case would be ceftriaxone plus azithromycin. Extended spectrum was any case where they used anti-MRSA therapy, anti-pseudomonal therapy, anti-ESBL therapy, usually carbapenem or ceftolozine tazobactam, and anti-CRE therapy. And you can see that the incidence of these, well, let me not try to go to the incidence. We'll see it in a minute. Next slide, please. So they had an interesting algorithm in this. So basically, they would look at a published algorithm that could be used to look at the risk of one of these MDRO organisms in causing community-acquired pneumonia. And these were non-ICU patients. So you were excluded if you were in ICU. And they were looking specifically at those patients that had an MDRO risk of less than 10% versus those that had greater than 10%. So if they had greater than 10% risk, it was considered appropriate to use one of these extended spectrum therapies. If you had less than 10%, you were expected to get ceftriaxone plus azithromycin. And basically that would come out in a recommendation. So this particular case, the person had ordered cefepime, and it comes out and says cefepime is not recommended as empiric therapy. The patient's risk is low, so they recommend ceftriaxone. And in order to go through and finish the order, you would have to accept that, or you could override it. If you override it, you had to say why. So you could basically give a reason such as allergy, the patient requires ICU care, neutropenia, other, and specify other. Next slide, please. So this looks at the outcome. So just take a point at the CPOE bundle on the left versus on the right, the routine stewardship. And for routine stewardship, once you get into the intervention period, you're looking at the rate ratio compared to baseline. And you can see that those numbers are all close to 1, meaning that there was no change in the use of extended spectrum antibiotics. On the left, with the bundle including the ordering support system, the rate ratios went down to about 70%. So you're getting more than a 30% reduction in extended spectrum antibiotics. And at the bottom, those are safety outcomes: length of stay, time to ICU transfer, and time to antibiotic escalation. And you can see that none of those changed by doing this intervention. And I believe that's the last slide, but you can check to the next one. Okay, great. So I'll turn it over to Dr. Huang.
Thank you so much, Dr. Nix. So again, everyone's welcome back. So I'm thrilled to shift the gear now and talk to one of the most challenging areas of stewardship with UTI. And then at this moment, we finished the respiratory tract infections in terms of the paper. But I will have more talking about today. We have a diverse audience here. So we have epidemiologists, we have clinical microbiologists, and we also have a frontline clinicians. So will agree on one thing, that diagnostic ambiguity is a number one enemy for urinary tract infection stewardship. So we are going to try to treat a true infection versus colonization. So let me move on to our discussion on my section area. So regarding UTI, there's clinical challenges that I sort of think about in these three manners. So diagnostic ambiguity and also insufficiency with tradition, antimicrobial stewardship, as well as upstream and scalable solutions where we needed to go with it. So a little bit for now, let's, before we leave the respiratory and then moving south to the bladder, there's one more last respiratory paper that I want to share with. And this one is critical because it addresses a massive issue in pediatric outpatients world, but volume is high and also decision fatigue is evidenced in this study. So we see that about 80 to 90% of all antibiotic use occurs in outpatient setting. And most of the respiratory tract infection where antibiotic might not be necessary, but they are prescribed. And when they do prescribe, most of it would be Ceftonir. And clinically, we know that Ceftonir is not really a great drug in so many ways, that is have poor absorption or short half-life and also have high protein bind. But yet often the go-to for penicillin allergy is probably Ceftonir. And studies show that in this study, they uses a best practice advisory alert or BPA to curb the overuse of Ceftonir. What we know is that outpatient stewardship is that clinician education demonstrate improvement in antibiotic prescribing and decision support system. Rather, an inpatient restricted antibiotic use a prospective audit and feedback is more common, but it's definitely more difficult to use it in outpatient setting. So this is a quality improvement initiative at Children's Hospital in New Orleans. And this is implemented an order set that guided providers to first-line therapy, and they also offer appropriate alternative allergies, as you can see on the top left, on the top right in the purple box. The intervention was a BPA and EPIC that will trigger when they order Ceftonir and selected for urinary tract, upper tract infection. If you look at the purple box up in the right corner, what it is that they have order sets that have guidelines specific. First line infection, for example, they can use amoxicillin for pharyngitis or amoxicillin/augmentin for acute otitis media or sinusitis. But they also have alternatives such as Ceftonir, clindamycin, levofloxacin for alternative. If you look below that, a BPA, it's illustrated a BPA. So as what Dr. Nix had mentioned earlier, what it does is that when you order Ceftonir, it trigger you with a couple questions. And that question, when you click, either you accept it or you move on for a reason behind why you choose those options. If you look at this visually, this is what providers face. This is a classic nudge type of ASP, and it doesn't really forbid provider from using the antibiotic, but it forces a pause to ask, is this really the best choice? And here's all the guidelines. What are your thoughts? Where you want to go with it? So that's basically what this study is about. So let's look at the uptake. So out of nearly 43,000 prescriptions, they trigger almost 3,000 BPAs. But here's a reality check for all of us. 40% of those were dismissed. And believe it or not, alert fatigue is real, folks. Like, we all know that, right? So click, 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 and then at some point, you're going to not want to click any longer. However, nearly about 50% were accepted. And interestingly enough, 5 providers generated a third of all the triggers, showing us that we needed to target this type of education toward this type of providers. But despite the dismissal, did it move the needle with one way or the other? Right? So what did we find? Apparently it does. It did move the needle. The intervention was associated with statistically significant decrease in Ceftonir prescribing, about 8.4%. As you can see the decrease here, while there are slight creep back in the late 2022, it's likely due to probably what we all kind of think about, the triple endemic respiratory surge, as we all remember it well. And overall, the trend remained lower in terms of baseline. So what is the takeaway? This is a suitable, reproducible intervention that we can do. It proves that even high volume outpatient clinics, you can use the EMR or EHR to drive the prescribing away from not to ideal agent, but more to a first-line agent that's supported by guidelines. So my next study, we're officially closing on the respiratory. So now let's next move to adult inpatient with the INSPIRE trial by Go Hill and the HCA healthcare team that Dr. Nix just mentioned, the companion trial. It's a counterpart to the pneumonia trial, but I would like to argue this implication here that it's even more profounding because the volume of urinary tract infection that we do see inpatient and outpatients. So we know that high recurrence UTI rates predispose patients to broad spectrum antibiotic use. We know that is a problem. When we have a patient admitted with UTI, they have a history of prior infection or recurrent infection. They may look sick, but the reflex for practitioner to do is to initiate broad spectrum antibiotic, such as vancomycin plus Zosyn or meropenem, what we call the big gun type of antibiotics, right? So the goal here was a diagnostic stewardship, identifying low-risk patient to spare them from the broad-spectrum antibiotics. So this study, like Dr. Nick's study, is a massive undertake. As you can see, it's over 59 hospitals that were randomized. They included non-critically ill adults patient in this study. They deploy similar thing as the pneumonia. They use the computerized provider order entry, the CPOE bundle, and they summarize this in the blue box. I summarize in the blue box in the upper right-hand corner. And it's a very patient-specific, it's not generic alert, it's very patient-specific risk model that this is built. It prescribes or order an extended spectrum antibiotic such as Zosyn or cefepime for UTI. The algorithm would run in background calculating this risk. If the patient's risk calculated for multi-drug resistant organism or MDROs was less than 10%, and less than 10% is a very conservative threshold, that said, it will message a prompt back say, this patient have low risk. And current guidelines recommend, for example, ceftriaxone. And crucially, this gave them a one-click button to make a choice. They don't have to go and search for an order set, no typing any drug. You just click and it will switch to the antibiotics that you chose. So the data set is pretty enormous. So we have about 127,000 non-ICU patients. At baseline, these groups were well matched. Approximately 40% of patients receive empiric extended spectrum antibiotics. Yet the study risk model showed that fewer than 6% actually had urine culture positive for MDROs. The CPOE bundle arm achieved about 17.4% relative reduction in empiric extended spectrum antibiotics days of therapy, as compared to traditional or routine stewardship. So you can see that in the upper right corner, the p-value. If you look on to the bottom right, it have a similar shift. Actually, you see a decrease in other antibiotics such as vancomycin gram-positive and also anti-pseudomonal agent. This confirmed that the intervention worked across other classes of antibiotics as well. By flagging these patients as quote-unquote low risk, provider might feel comfortable stripping away all the access coverage, not just the gram-negative, but also probably gram-positive. And as a clinician, questions always, did we hurt anyone by narrowing these therapy? Safety outcomes show no difference in hospital length of stay, days of ICU transfer. We successfully de-escalate patient to therapy without compromising safety based on the study. So this graph visualize the shift in prescribing behavior at patients' level over time. So look at this graph. It tracks the percentage of individual patients who receive only standard spectrum antibiotic versus those receive extended spectrum agents. On the left, we see that the groups are identical at baseline. 60% of the patients is in the orange line when you see the closed circle. They're getting the standard therapy, while 40% in the blue and the gray receive extended spectrum antibiotic. So on the right, the intervention period, you can see in the orange line, it trends to go upward, meaning that significantly more patients are successfully treated with standard spectrum antibiotic. But if you look at the solid blue and gray lines, the intervention, they tend to trend downward compared to the nudge ASP in terms of shortened therapy. So then when you look at the open circle, the lines seem to be relatively low risk. And then so the prescription behavior seemed to remain stagnant at that point. So here's the most shocking finding for me is that algorithm determined 94% of those patients were low risk for MDROs, but yet the baseline group, 40% getting the broad spectrum agent. So the gap is between that 6% real risk and then 40% treatment. And this is the fear gap, right? The study proves that we can still use EMR tools to close that gap. It gives us a blueprint that we don't educate, but give provider the risk data at the prescribing level. Okay, so the INSPIRE trial gave us the macro solution for large health system, but now we still want to dive into the universal granular problem that plagues the hospital, which is the challenges of true infection versus colonization, the ambiguity of the root cause of this inappropriate antibiotic exposure. So Gilbauer and colleagues tackled this diagnostic heads on. So in these hospitalized elderly patients, specifically those who are poor historians or who are nonverbal, the prevalence of asymptomatic bacteriuria can exceed 30%. But yet, because of the non-specific symptom, such as elevated temperature or mentation, we default to ordering urine culture. The unnecessary urine culture trap us into positive result, which compel us to want to treat the patient. So despite patient symptom due to non-infectious source. So this paper sort of break down that cycle of at the diagnostic front line is what we need to do. So the study objective is highlight the challenge of the overdiagnosis and overtreatment of UTI in an acute care setting by developing and testing 3 questioned clinical decision support tool. These are adult patients that have been receiving treatment for UTI across 4 hospitals in acute care setting. The intervention is that 3-question tool that utilizes or visualizes the logic of the 2 you can see on the right-hand side. It's a sequential type of filter. So what the author developed is that consensus decision support tool to standardize when to culture. So they follow these 3-step rules. Is there a clear must culture indication, such as pregnancy? 1. 2, are there localized symptoms, such as dysuria or urgency? If not, the systemic symptoms, such as fever, with no other alternative choices. If the answer is no, then we shouldn't move forward in ordering culture for the patients. So if you look at the result in the baseline, we have about 29% of the patient are considered poor historian due to dementia or altered mental status. And this is crucial as these patients cannot reliably respond or answer regarding their symptoms. So the absence of clear history, clinicians often default in ordering UA and urine culture. If you look at it, 31% inappropriate treatment. So patient receive treatment for asymptomatic bacteriuria, which is not necessary. because that lead to us over-treating the majority of what we misuse the antibiotic. So if you look at the 3-question tool in performance, we look at sensitivity and specificity, right? So it's about 99% and 100%. So what does that tell us? Sensitivity probably tells us that correctly we identify nearly all patients who truly needed the antibiotics, but specificity, then what that does is that we probably correctly identify patient who did not need the antibiotics. So the key takeaway here is, if you look at it, it's a simple cognitive tool. It's highly effective, differentiating true infection versus colonization, probably outperform the standard practice. And the table below that is talking about the listing of asymptomatic bacteriuria, pyelonephritis. Seeing the more to listen on that is ASB. So just quickly on this slide quantified the burden of inappropriate antibiotic use that identified during the retrospective validation of these 3 questions. So figure A, to your left, this is a stack bar that confirmed about 34% or 1/3 of all antibiotic days prescribed for UTI were actually for ASB. And then figure B, to your right, this breakdowns those days by specific antibiotic show where misuses happen. Example, 3rd-generation cephalosporin. This represents the highest volume, and half of the days of therapy were inappropriate use. So the silver lining is that there is a very low inappropriate use, approximately 2 days, suggesting that providers are appropriately reserving these for a confirmed and complex infection. So the takeaway is that this low-tech, high-impact solution, you don't need expensive AI model to work with this. So all you need is this checklist. If you implement this before the culture is ordered, then you can stop the antibiotic cascade before it starts. So now let's talk about CARDI with Sampson and colleagues. So we all know that the rule, if a patient has a catheter for more than 3 days, then they will have bacteria. And a positive culture, meaninglessly without symptom, you may have to pan culture for fever. You may have to still have standard practice. So this study sort of introduced the hard stop intervention. So the studies evaluate impact of computerized diagnostic stewardship intervention, which is the clinical decision support system, CDS. They designed to optimize urine culture in patients with indwelling urinary catheters. Catheterized patients are at high risk for colonization. However, positive culture often triggers unnecessary antibiotics that lead to CAUTI for the surveillance purposes. This study includes adult patients greater than 18 years of age. They focus on hospital day 3 or later with indwelling urinary catheter. And this day 3 consider hospital-acquired infection. The intervention is a hard stop alert, and the table on your right show that the actual BPA that providers see. And the message usually pretty explicit when it's flagged. Urine cultures catheterized patient usually represent colonization and not clinically meaningful. So is this a direct education nudge? So it forces provider to either justify that they need a culture or give it a criteria to why they wanted to order a culture, basically. So did it work? Absolutely. The BPA averted 52.5% of all provider initiated urine culture, and that more than half of the workload removed from the microlab. If you look at the bottom bullet there, the graph on the right-hand side is sort of, despite removing half of the culture, there are no statistically significant differences in the hospital NHSN CAUTI rate at all. So the trend lines is shown that continue gradual decline. There is no dramatic step down at the intervention point. So this provides powerful evidence for the safety of no urine culture policy for asymptomatic catheterized patients. It will empower stewardship team to be bold so that we can turn off the testing tap. And if patient truly septic from urinary sources, then it means that criteria or ID can get involved. So everyone else by saving unnecessary treatment for our patients. And finally, last paper, we're going to head to a long-term care facility rehab setting and looking at the bladder score study. So the background of this here is pretty crucial. So when we look at long-term care facility, over 50% of patients have bacteriuria at baseline. So we don't have ID pharmacists, lack of resource on unit. So discontinue the order, and rather we have nurses initiating these diagnostic cascade or to pretty vague symptom or confusion like. So Langford and colleague recognize that this is the setting. Nurses are the gatekeepers, and they all ones that calling the doctor probably at 2 a.m. in the morning saying, hey, Mrs. Jane Doe have urine that have strong smell, some sort of things like that. So they implemented a boosting tool that's called bladder score. If you could see it listing onto your right. So for example, B stand for blood. So that's the listing that you can see. So this methodology slide set in a stage that introduces simple, memorable, evidence-based tool that's designed to empower clinician. It shifts the focus from a gatekeeper to discontinued order and boosting the improvement of diagnostic in challenging clinician in this environment. It's a simple pneumatic to empower nurses to assess. So to your right, you can see what it all means. But if the score is less than 2, the protocol is do not culture. Simply monitor and hydrate the patient. So this is done in a 134-bed complex. So the study design looks at, this study focused on high-risk elderly, mean average age 76 years old patient, complex continuum care, rehab hospital characterized by a long mean length of hospital stay. They have it for 36 days. The key finding is that there's a reduction in antibiotic use, which is most significant finding for decreased use of antibiotics. They see a usage drop about 26 defined daily dose per 1,000 patients day post-intervention, as you can see it in the 2 graphs on the right. And this reduction from the baseline, it rate about 41 DDs per 1,000 patient day. And this image here typically show that pre-intervention trend line compared to the post-intervention trend lines seem to be highlighted down to the lower right. So in summary, this study is less about raw numbers, but more about the method. The study is a proof of concept for boosting, which is active education intervention that enhances competency rather than nudging, which is more passive, often subconscious influence on choices architecture. So it's respect the clinician autonomy and aims for long-term behavior changes by giving them a tool to make a better decision rather than put barrier. So nurses often want to initiate these diagnostic cascade. So empowering them with these criteria to not send a culture is a high leverage stewardship strategy. However, by throwing the kitchen sink, if you will, at the problem, we can't say for sure that if the score alone did the heavy lifting, especially since practice was already improving before they even started. So to summarize what Dr. Nix and I have talked about today, is that is the most constant theme is moving the interventions upstream and then to the point of diagnosis, focusing on controlling the input of the prescriber decisions. All study leverage the scalable tool, so EMR, EHR alerts, pneumatics, simple checklists, guide high volumes. And then lastly, the remaining of gaps that diagnostic stewardship can be dramatically reduced to testing, surveillance metrics, but also passive nudges with nuances, decision, and the durations, like duration of therapy could really help us. So really, that is the end of our talk, and we'd be happy to take any question you may have for us.
Okay. Well, thanks for the excellent reviews. The first question I think, is from Dr. Tofam. Many studies use diagnostic stewardship to reduce testing, like respiratory and urine cultures. However, in outpatient settings, diagnostic ambiguity often leads to antibiotic treatment without testing. How can the principles of diagnostic stewardship be applied to conditions like upper respiratory tract infection or asymptomatic bacteriuria in the outpatient setting, where the primary goal is not to reduce culturing, but to prevent the initial prescription?
So I'll start out. Since basically, I think the key issue is to require diagnostic criteria. So if you're talking about urinary tract infection, you've got to have urinary symptoms local. And if you don't have that, you shouldn't be culturing and you shouldn't be treating. So that would be in that setting. If you're talking about upper respiratory tract infections, to get more specific, if you're sinusitis, for example, you generally don't treat sinusitis within the first 5 days or so. If you have a common cold, you may have symptoms of sinusitis, but you want to wait 5 days into the illness and see if it starts to improve versus get worse, and whether or not the patient has more severe symptoms and all that. So I think just relying on the diagnostic criteria and not the laboratory results is what's important.
Yeah, I would agree with Dr. Nix as well. I think just symptomology and then all the information you can have, and then try to gear away from treating the viral infections and really hone on. And at the same time, too, is probably looking at the guidance, and not just because also patients, you have to talk with the patient because they're not feeling well and they going to want some sort of antibiotic, and that's more upper respiratory, right? And urinary tract is, you got to know what the recurrence in the patient, what are they coming for, and ability to understand that would help streamline.
Thank you so much to our amazing speakers, especially Dr. Nix and Dr. Huang, for staying into this and still be extremely engaging and provide the nuts and bolts for stewardship so that our attendees can take home with.